Hi, my name is Ana Cláudia. I am a stroke neurologist from Hospital Moinhos de Vento, Brazil. Thank you very much for the invitation to participate in such a great event in Colombia. And now I'm going to present our project, Unveiling the Cost of Acute Stroke Care in Latin America, a comprehensive analysis. It is a pleasure to inform you that our project received a grant from the World Stroke Organization, and so we are supported by them. Actually, I am the principal investigator, and we have a lot of important members as sub-investigators that helped to build this project. Ana Paula, Eva Rocha, Miguel Barbosa, Pablo Maia, and we were mentored by Gustavo Sapoznik and Sheila Martins. We already know that stroke has a huge mortality, disability, and socio-economic impact. And we expect that increase in stroke burden will be higher in the next years. Also, we have a high economic impact in low middle income countries when we compare the impact with the developed countries. We also have few studies related to stroke treatment costs in Latin America. And we have a lack of methods for evaluating costs. Mainly, the studies published, they don't have so accurate methods to obtain the real costs of the acute ischemic stroke treatment. So it is very important to have these accurate and standardized models to obtain more reliable results. This is the first economic evaluation collaborative project in Latin America, and we aim to measure the main direct costs associated to the stroke treatment through accurate costing methods. For example, the micro-costing and the time-driven activity-based method that I will explain it further in the methodology. We will perform economic evaluation of new strategies, new treatment strategies in selected countries. And through this data, we aim to give subsidies to the decision makers and health managers from each country to better allocate healthcare resources and to incorporate new and effective technologies in the public and also in the private sector. Our project is divided into phases. We will have a pilot study, and the objective of this phase is to assess the feasibility of the project. We will obtain costs and outcomes from 5 centers, and we will perform economic evaluation with the provided data if this data collection proved feasible. So we will migrate to a phase 2 that will be our main study. Here we will describe the direct costs of the acute ischemic stroke treatment, and we will compare this data between different types of stroke centers. And also, when it is convenient and in selected countries, we will perform cost effectiveness analysis of intravenous thrombolysis or mechanical thrombectomy when necessary, and respecting each country's particularities. Here, our methodology, so we will divide our study in 2 phases, the phase 1, the pilot project with 5 hospitals, and then if it has been proved feasible, we will migrate to the phase 2, our main project, and we will add more 5 hospitals, and we will start with our prospective phase that we will obtain costs and effectiveness data from each patient that enter in each hospital with acute ischemic stroke. So it is a cross-sectional study that we will obtain data from March 2021 to August 2022. Study participants will be patients over 18 years old with confirmed ischemic stroke at hospital discharge. And selection of participant hospitals. It is very important that these hospitals treat about more than 100 stroke patients per year. So in the phase 1, we will include 5 hospitals. We plan to include 2 in Brazil, 1 in Argentina, 1 in Colombia, one in Chile, and one in Costa Rica. We are still contacting these countries, and we are still looking if it is possible to obtain this cost and effectiveness data. And when this phase ends, we will analyze the retrospective data from patients admitted in the last 3 or 6 months, but it will be a minimum of 30 consecutive patients per center. And then we will analyze if we can migrate to the phase 2, that will be our main project. Here we will select another 5 hospitals, totalizing 10 hospitals. And these 5 additional hospitals will be the hospitals that already participate in the certification stroke centers program that also has been supported by the World Stroke Organization and will improve the quality of stroke care in Latin America. So hospitals applying for this certification will be also invited to participate in our project, and we will select them if they are if they have the main characteristics that we are looking for. Data from all consecutive stroke patients prospectively admitted in this period will be analyzed. And how are we going to obtain our costs? It is very important to differentiate between the direct costs and what is the reimbursement payment. For example, in our methodology, we are looking at a patient level center. And what does that mean? That we are going to assess everything that the patient consumed during the stroke treatment phase in the hospitalization. So we call this micro-costing method. We analyze all service of professionals involved per hour worked, daily admission at stroke care unit or intensive unit, all exams performed, medications, thrombectomy materials used, the procedures and use of facilities. Also, we will consider for some patients the readmissions, outpatients consultation and rehabilitation. So this is very different of what is reimbursement, that in some cases it is it is a total amount that the government pays to the hospital for each patient with acute ischemic stroke. This is not the real costs that we are going to analyze. We will analyze the direct costs involved in the stroke treatment and through a micro-costing methodology. Also, we will consider another methodology that is called time-driven activity-based costing. This gave us more accurate data for costs. For example, we create process maps to identify all the resources consumed in each macro phase during the hospitalization, since the patient arrives at the emergency department, goes through the radiology to perform the exams, goes to the angio suite, and after that the stroke unit. We analyze what did the patient consume in each of these phases. Also, we will review the medical records and prescription to obtain what were used during these phases, and we will obtain and work with the financial departments of each hospital. It will be very important to have this approach with these departments. We will analyze the resources variables, for example, personal, corporate, and divisional allocations, medication and medical supplies related to each phase, as I previously said. Here it is an example of our main spreadsheet that we will send for each selected center that will participate in our project. Here it is a part of the labor costs, for example, costs, the monthly salary, benefits, and taxes, hours hired per month of neurologists, anesthesiologists, psychologists, nutritionists, all professionals involved with the stroke patient treatment. Also the structure costs, for example, depreciation, energy, support, supplies, and capacity information, number of beds, hours a day working, days a week working, All this information is very important to create our formula and to obtain the direct costs accurate. Here it is an example of the costs of exams. We will only analyze the exams that have a real impact in the final cost for the patient. For example, CT scan, RMI, echocardiography. We will analyze the number of exams performed for each patient, and also we will ask for the cost per exam. That these answers they can be obtained by the financial departments. We will also consider all materials used per patient during the thrombectomy procedure, for example, number of femoral introductors and the cost of excision, number of cello, balloon guide, number of microgears, number of penumbra and solitaire. This is very important to understand. We will only achieve the cost of the exams and medications and materials that real impact the final costs, and also the cost of alteplasies. Outcomes evaluated will be demographics, data, mortality, and hospital length of stay that will be collected. Ranking scale and National Institutes of Health stroke scale, the NIH, will be used. And ranking scale that will be assessed will be the hospital discharge ranking scale and the ranking scale at 3 months. Here, just a table to summarize the main outcomes that will be evaluated. For the cost effectiveness analysis, we will compare the costs and effectiveness of treatment strategies in selected stroke centers, and we will compare between minimal, essential, and advanced stroke centers in the same country. This is very important. Through the cost effectiveness analysis, we will obtain the incremental costs, incremental effectiveness, and the main results that we are looking for, the incremental cost effectiveness ratio. And to calculate the cost effectiveness of the treatment strategies, we will use an important scale to calculate the effectiveness. And this will be obtained by utility weighted ranking scale. It is a method that we can calculate the quality adjusted life years. For example, the utilities, they range from 0, that is the worst perception of health, and 1, that is the best state of health that one patient can achieve. And this scale was built through the perception of stroke patients. For example, patients analyzed that when they are in a ranking modified score of 5 and 6, it is the same. It is the same to be very functional, impacted, and to be deaf. It is the same. And as the ranking score improves, they gave better results for the utility modified ranking score. We choose to use that because we have published that data for stroke patients. So we will use to calculate the QALYs in our study. Also, to assess the robustness of our data, we will perform sensitivity analysis, for example, the deterministic sensitivity analysis and probabilistic sensitivity analysis with the input parameters that will be long-term transition probabilities, mean cost per ranking, and discount rates. Here it is a schedule that summarizes the main phases of our study. We plan to perform our study in 1 year, and we will start with the selection of stroke centers. And well, we will submit the protocols of the project to the local ethics committee of each center. After this regulatory phase, we will migrate to the training of the selected stroke centers. We will train all the staff team and capacitate them to collect the data, cost data and effectiveness data. After that, we will have a period of data collection and a monitor of quality of cost and effectiveness that will be held by the the principal hospital investigator. And after that, we will analyze all the results to perform the cost effectiveness analysis in selected centers, and we will present our results in the next World Stroke Congress in Singapore that will be held in October 2022. So we have a lot of potential impacts of our project. And the main impact is that we will understand the real costs of acute stroke, applying this microcosting in time-driven activity-based costing. So this is the first time that in a lot of centers in the same time, we will try to apply this methodology in a standardized spreadsheet that we already created. Also, it will give insights and answers on how to allocate and to optimize resources better, and also to rethink the reimbursement models that each country has actually. These concepts to improve the stroke services based on value-based healthcare could bring the stroke treatment to another level here in Latin America. So we believe that our project can encourage changes in national health policies for each Latin American country. Also, we can improve the resources allocation and improve the quality of stroke care, reducing the socioeconomic impact of stroke in Latin America. So we count on you. Please join us. If you are interested in our project, please contact me. It will be a pleasure to analyze and to work with all of you and to change this socio-economic impact of stroke here in Latin America. And first of all, understanding the real cost of the disease. Thank you very much for the opportunity.